Today, we're playing Full Code, a popular medical simulation game. And last time, although I correctly diagnosed a patient with supraventricular tachycardia, the rest didn't go so well.
Rock was harmful. No, this is not what I need for a patient.
So I brought a trusty quick sheet of medications and about 9 months of experience to see if I can crack the case and properly diagnose and treat this patient. Let's go. Cases. And you can see I've already completed some of these. Gives me a random case. Okay, case introduction. Sent in from urgent care via a private vehicle. Triage, 29-year-old man sent to ED from urgent care with abdominal pain since yesterday. Nausea, no fever. Now, again, I'm an ED tech, but I don't see too many calls and I'm pretty young, so we will see how I treat this. First, let us talk to the patient. Overview of this patient. Okay, patient presented to the ED due to worsening abdominal pain, poor appetite, nausea, chills. Key considerations. So right lower quadrant has tenderness. Down here, evaluating for signs of peritoneal irritation. The peritoneum is a tissue layer around the abdominal area, and ordering appropriate laboratory tests and imaging studies. So in that area, I'm probably going to want a CT scan, possibly x-rays too. Not great for soft tissue, but we will work through that. So let us talk to the patient. Okay. What brings you in today? His stomach hurts a lot, especially in the middle and right side. Also feeling nauseous but haven't thrown up. Not really expecting appendicitis or ruptured appendix. His age is younger, 29, but we will see. So I want to, of course, first get a quick airway exam, breathing exam, and then circulation exam. Again, basic ABCs, every EMT, we learn this, it's beaten into us, over the head, and then beaten again. And then I want to, of course, get a EKG and IV access. Nausea means could be dehydrated, we don't want him getting worse. So let us stabilize, insert IV as attached monitor, and I'm going to try to find out where the EKG is. I always forget. Let's get some lab work. Let's do basic chemistry, blood type, no, not blood type and screen. Let's do a blood culture to see if there's any infection. Let's see, COVID-19 test, sure. Let's get a CT scan of his abdomen also. So trying to get some basic exams. Last time I think I forgot the EKG. I'm not doing much better here because I still haven't found where the EKG is. But we will try to see here. Doesn't need oxygen. Current stats, 116, slightly tachycardic. Normal temperature, oxygen sats 98 to 100. Respiratory rates within normal range of about 12 to 20. Blood pressure is 124/70 within normal ranges. So let us see where cardiovascular, okay. So the lab results are in. I'd also want to make sure a vomit bag is near his bed or gurney so that he would not aspirate it. That could become a problem. Communicate. So let's see. Gastroenterology, probably wouldn't need to recommend them. That's kind of excessive, but doesn't hurt in the game. So yeah, recommends a careful abdominal examination. Yep, makes sense. Imaging, okay. So CT of the abdomen. COVID-19 test, negative. Hurrah. Blood culture is still in progress. Basic chemistry. So we have sodium, potassium chloride, all that. I was hoping, yes, they do have normal ranges. Looks good. Looks good. Looks good. Looks good. High but good. Creatinine and glucose, all within normal ranges. So I'm not suspecting anything too severe there metabolically. Infection and or some sort of internal stomach reaction is my highest suspicion. He's again guarding, he's pushing on his right lower abdominal region. So let us see and then the CT. So I'm not great at reading x-rays. I did a little radiology online shadowing. A trick that often med students do is they look really close. They said, look away, try to see big picture. So I'm looking for any distension of the abdomen, any different body fluids that could be leaking. And so it looks like there's good bilateral symmetry of the right and left side. The picture is small. Ooh, I can make it larger. So you see here A 17.1 millimeters. There is a non-fluid filled edematous appendix with acute appendicitis. Looks like I should have been more cautious ruling out appendicitis. Again, anything right side, and when he said the middle around the navel region, it can radiate, so that should have been a suspicion. So we need to get him to surgery ASAP. So let me try to continue stabilizing, he doesn't need that. Okay, we will consult general surgery. General surgery will remove his appendix. Surgeon's finishing the OR, but based on CT findings, we'll recommend sending the patient to OR for an appendectomy. They'll meet the patient in the pre-op area. Awesome. So that sounds good to me. We will prep for the OR. And this has turned out to be a lot clearer case than I expected. And so my final diagnosis, I need to add in the differential. I don't need the ICD-11s here because I just need to choose one. So we are going to go with gastroenteritis appendicitis. It is acute appendicitis. That is my final diagnosis. This has turned out much easier than I expected. I hope I'm not too cocky. Here we go. Hubris is the fall of great men. Hand off. Prep for operating room with a diagnosis of appendicitis. Am I sure? Are we ever certain in medicine? Probably not, but I'm pretty sure. So we are going to finish. Wow. I honestly thought I'd have a higher percentage score. 75.5% was my final score. I correctly diagnosed it as appendicitis. That guy got rushed off to the OR, got his appendix removed, and is on the mend. But I'm rather curious what I did so wrong. Well, regardless, case number 158, lower abdominal pain and vomiting, appendicitis was the diagnosis. So with that being said, I hope you enjoyed this quicker video of full code. I didn't make any massive blunders like the last video, so maybe I'm learning, or maybe I just need a harder case. But if you liked this video and would like me challenging myself with a harder case, then make sure you subscribe, let me know in the comments below, and as always, ad meliora toward better things.